Hello everyone, welcome to this new IWC webinar. We are very happy today to welcome two IWC teams, one from Stanford, IWC Stanford, with Jeffrey Yao and Eric Chang. And we have also the team from Lisbon, IWC Lisbon, with Carla Nuñes and Raquel Teixeira. We will have, as usual, two very interesting clinical cases to discuss. Just I would like to remind you that, as usual, we want this webinar to be interactive. So we will have some polls during the cases. So we invite you to answer the polls. And to ask your question, we will have Gustavo Gomez and Lucian Marcovici, as usual, who will be my co-moderators. So we have 1 hour. I would like to thank everyone, the speakers, the moderators, the panelists, for connecting. So we will start right now with IWC Stanford, the first case. Eric, are you ready to share your screen, please?
Yes. Yeah.
Thank you, Eric.
And then I just want to make sure that everyone can see my screen right now.
It is perfect.
Okay, great. And then I'm going to enter the presentation mode. Thank you for that introduction. My name is Eric Chang. I'm one of Dr. Yao's hand fellows at Stanford, and I'll be presenting a case today on ulnar-sided wrist pain. So the history of our patient, he's a 45-year-old right-hand dominant male with a history of left TFCC, or triangular fibrocartilage complex injury, status post a previous injury, and an operation with Dr. Yao. He was doing well for 6 years and then presented with a new ulnar-sided wrist pain on the same side. He's very active with recreational sports, particularly with softball, which is pictured on the right there. And then he felt a popping sensation on his left ulnar wrist during one of his softball games. He has obviously been through this before and tried many conservative treatment modalities. So he went back to his wrist widget, which I'm not sure if everyone's familiar with that, but there's a picture of that on the right as well, and has been refractory to conservative treatment measures. So just to quickly review his past surgical history, since it's a bit complex, in February of 2013, these are all with Dr. Yao. He underwent a left wrist arthroscopy with TFCC debridement. At that same time, the lunotriquetral ligament, the LT ligament, underwent thermal shrinkage and a lunate microfracture as well. So he was doing well for about 6 years. And then in June of 2019, he underwent another wrist arthroscopy and debridement of the TFCC again. And this time, Dr. Yao added an ulnar shortening osteotomy. So seems like every 6 years, he comes back with a new injury, a new pain. So we're talking about after June now. On exam, his appearance was normal bulk and contour. You could see the previous arthroscopic and ulnar border incisions were well healed without complication. His sensation was intact in median ulnar and radial nerve distributions. He's able to make a composite fist and warm and well perfused. On provocative maneuver examination, he was tender at the ulnar fovea, tender with the press tests, and tender, positive with pain with hypersupination as well. So I'm going to move on to his imaging now. So here we see 3 views of the left wrist, AP, oblique, and a lateral. It's notable for previous ulnar shortening hardware. It looks like the osteotomy healed well without complication there. And then some mild DRUJ arthritis. I'm going to click through these MRIs, and hopefully they will also show. Let's see. So starting on the left here, this is a T2 weighted image from dorsal to volar in the coronal plane. And then on the left, and these are going pretty fast, this is a T2 weighted image from radial to ulnar in the sagittal view. And then I'm just going to try and see if I can pause at the right time here. past it already. Hold on 1 second.
Take your time. You have time.
Okay, sounds good. Maybe stop around here. So on this MRI, again, we can see some DRUJ arthritis. There's increased signal here in the TFCC, and then there's chondral thinning of the lunate here as well. There's also moderate articular disc thinning in the TFCC debridements and injury.
Okay.
So I think I'm supposed to pause on this next slide. So our assessment and plan. I'll stop at the first one. Oh, yeah, there we go. Okay.
Yes.
So this is our 45-year-old male with a past medical history of previous left TFCC injury and 2 surgeries, including an ulnar shortening osteotomy with new ulnar-sided wrist pain.
So thank you, Eric. I think we can make the first stop for some because it's a complex case of recurrent ulnar-sided pain after 2 surgeries. Do we have some comments, some questions for the first surgeries? Jaime, you are just in front of me. Do you have any comments, any question to ask Eric and Jeff for this case?
So yeah, I have one question. Nice presentation, by the way. The lunate microfracturing was due to ulnar impaction before doing the osteotomy, or what's the rationale after that?
Jeff, you can answer too.
Okay.
I'll give Eric a chance to answer.
Yeah.
Okay, yeah. His preoperative variance was slightly positive. I guess there wasn't any direct impaction, but it seems like there may be some component of that. But that was corrected. I wasn't there at the first 2 surgeries, Dr. Yao, but you must not have included the osteotomy on the first time because you didn't think it was grossly positive.
Yes. So basically, the first time we went in, did just a simple TFCC debridement for central tear. It went well for 6 years. He had a new injury, and at the time of the new injury, we don't have the imaging from there, but he had ulnar positive variance of approximately 2 millimeters. But importantly, during arthroscopy, we did identify a lunate lunate impaction lesion, chondral lesion on the proximal ulnar border of the lunate, and that's why we proceeded with the ulnar shortening osteotomy and the microfracture.
Thank you, Jeff. So if we understand well, the first surgery in 2013 was only a debridement on the TFCC. It was not a repair.
That's right.
Okay, and debridement on the central tear and the lunotriquetral debridement was. Why did you perform to understand the lunotriquetral shrinkage or debridement? I don't remember.
Yeah, thermal shrinkage of the LT ligament. Based on the Geisler classification, it was a Geisler 2 LT ligament injury that we treated at the same time. Our preference is to do thermal shrinkage unless there's gross instability. We believe that not only tightens the ligament, but also provides some pain relief, as the thermal treatment does lead to, in the laboratory, we've shown that the thermal shrinkage does lead to loss of neuronal markers in the area that's been treated. So we feel that provides a denervation effect as well as the tightening effect.
Thank you, Jeff. So if we try to sum up 2 previous surgeries and now recurrent pain, I would like to ask our panelists. I have just in front of me Lucian. I launched a poll for the attendees. What do you think is most likely driving this patient's pain symptoms right now? When you see the patient at your consultation, I
wanted to know how was the clinical examination, if he had some signs of instability like DRUJ instability or lunotriquetral instabilities. Does he has an impaction, a positive impaction test of the ulnar carpal bones. So do you have some information about it, Jeffrey or Eric?
So very good question. I don't want to give up the entire case now, but it's a very important point in that sometimes the physical findings on the ulnar side of the wrist can overlap, and the specificity of those tests may be limited. As Eric presented, he did have pain at the ulnar fovea with a positive TFCC grind test. Also pain with hypersupination. I don't know if it was in the presentation or not, but was also some pain in the area of the LT ligament area. But as you can imagine, these tests are maybe sensitive, but not particularly specific for any specific pathology. We'll learn more as the case progresses, but suffice it to say that he had many tests that were positive on the ulnar side of the wrist.
Yeah, as he an athlete, okay, so sometimes athletes have a lot of imaging that is not good because they have a physiological wear of the joint because they do a lot of impaction, during their activity. So I think that clinical testing is very important, and it's very important to hear what he's complaining about more than the imaging, because he had also 2 other surgeries which can influence the imaging.
Another very good point, an important point. The imaging can be very unreliable because of the previous 2 surgeries. The tendency, at least in the United States, for anyone with ulnar side wrist pain is to focus on the TFCC. But what we're trying to illustrate here is that there are other causes of ulnar side wrist pain, not just the TFCC. And so these are all very good points that you're bringing up, Lucian. So should we proceed, or I don't want to give up too much of the case.
We are trying to find out how, if you to explain, if we see, my question, if you see for the attendees, if we see this patient at the consultation, what are the main hypotheses at this time before decision making? That is the main question. How do you manage this kind of case? Gustavo, I see you're just in front of me.
Well, I think, as Lucian said, I think that clinical examination in these cases is very, very, very important. And what I try to do all the time is to touch each structure from outside the wrist. So I touch the foveal side, I touch the triquetrum, the LT joint, the proximal pole of the hamate. So I try to see, because sometimes we have a plica, and this is the source of the problem. So I think clinical examination is the most important thing.
Thank you, Gustavo. Yeah.
In some situations, maybe in the United States, it's more common, but often you'll do your examinations on the ulnar side of the wrist. You'll do all the tests, as Gustavo just mentioned, and touch all these areas. And our patients will complain of pain in every single one. And so that makes it sometimes difficult from a diagnostic standpoint to really know exactly which of all these different structures on the ulnar side of the wrist may be the offending problem. I don't know if that's just unique to our American patients, but sometimes I find the physical exam can be a little bit maybe not misleading, but not particularly helpful as our patients complain of pain everywhere.
So it's not enough specific for you. That's what we can say. So if nobody has other comments, I think Eric, you can go on with your presentation.
Okay, sounds good. I see another poll up. Okay, there we go. Never mind.
Yes, I am going to stop to share it just to
Okay.
see because most of the people would go for arthroscopy to identify the pain generator. That is
Okay.
the point, and we will see what you propose now.
Yeah.
Thank you.
Yeah, so kind of to what a lot of our commenters have already alluded to, the sensitivity, the non-specificity, and then the imaging being confounded by multiple previous surgeries. You may not exactly know what you're going to get, but our plan was a revision left wrist arthroscopy with TFCC debridement versus repair, and then thermal capsulorrhaphy. So basically, we're going to go in there and check it out and see what's going on. So I'm going to go through some arthroscopic images now. These were images from the patient previously. These were in 2013, like the first surgery that we were just talking about, the lunate microfracture. So that showed obviously the microfracture all, as well as some good blood inflow afterwards. And then on our second look arthroscopy, when we went back, we were obviously able to take a look at how that area was doing. You can see this fibrocartilage ingrowth here on the undersurface of the lunate. So shows us that microfracture does do something for the lunate.
Sorry, Eric.
Yeah.
Sorry to interrupt, but I think the microfracture images, I believe, were from the second surgery. The first surgery was just a debridement of the TFCC. The second surgery was the microfracture, if I remember correctly. Anyway, the purpose of this is to show that the ulnar impaction lesion is identified, and that's when we do the microfracture. And we had the opportunity on this most recent surgery about 3 months ago to look back at that lunate, and you could see the resurfacing of the lunate has occurred, not with hyaline cartilage by any means, but with cartilage. I think Eric has some papers to show later to show the efficacy of microfracture for these ulnar impaction syndromes. So sorry to interrupt.
No worries. Okay. So moving on here. So now here are some from our intraoperative photos. Again, so this is ulnar side of the wrist with some synovitic findings and TFCC degeneration. Here's the introduction of the arthroscopic shaver. And then afterwards, after the debridement. And as we move on, this is a view from the mid-carpal portal of the lunotriquetral interval. This is a Geisler 2 for the lunotriquetral ligament. You can see the introduction of the probe here between the two carpal bones, and then again the thermal capsulorrhaphy that we undertook for this patient. And lastly, what we're looking at, this is probably hard to see, but this is the undersurface of the hamate here. And you can see a full thickness chondral injury right here. This is, like I said, the proximal pole of the hamate, and then again, the introduction of a microfracture all there.
All right. So this is from the midcarpal joint, midcarpal arthroscopy. We identified a hamate lesion, which we did not anticipate, but this is the benefit of the arthroscopy, is that we look throughout the entire joint, the midcarpal joint, the radiocarpal joint, and the disparietal joint, and we identified this as the potential new cause of pain for him on this new injury 6 years later.
Thank you. Okay. And then so just to fill out our full assessment and plan of the same patient, what we did was a revision right wrist arthroscopy with TFCC debridement. The scapholunate and lunotriquetral ligaments were thermally capsulorrhapized, and then hamate microfracture as well. So that was the completion of all of our procedures. Did you want me to pause here before we go through the articles, or?
No, go to the article. We will do the discussion at the end, because I think you have a lot of comments and questions.
Oh yeah, sorry.
Thank you.
So just quickly, the patient's doing well, was seen very recently. His pain has completely resolved. This is our post-operative protocol for this patient. So he was casted in a thumb spica cast for 6 weeks for a microfracture. He was transitioned to a removable wrist brace after the 6 weeks for sleep or increased activity. And then he is beginning to work with therapy for range of motion and progressive functional strengthening at this point. To go through our articles, this is our first article titled Arthroscopic Techniques for Wrist Arthritis, Radiocelluloidectomy, Proximal Pole Hamate Excisions by Dr. Yao in Hand Clinics in 2005. It's an anatomy and techniques paper on evaluation and management of proximal pole hamate lesions. This was initially described by Burgess in 1990 and termed hamate arthrosis lunotriquetral ligament. Triquetral ligament, so it's HALT ligament, analogous mirror lesion to the radial styloid in slack wrists. And it showed anecdotal good long-term results with chondroplasty and microfracture. So we'll go through some of the figures of the of the paper real quick. So as many of you guys are aware, there's 2 types of lunate articulations. With one of them is type 1 here, as you can see. And then type 2, there's a medial facet here that articulates with the proximal pole, the hamate. And patients that are type 2 are at higher risk of developing this HALT lesion because of this extra articulation. So here are just some additional arthroscopic figures from the paper showing this proximal pole, the hamate with chondral injury, as you can see on the bottom photo here. So Dr. Yao, I don't know if you've had any additional comments, but I can talk about real quick. The slack wrist, meaning the laxity between that ligament, the SL ligament, causes flexion of the scaphoid, which impinges on the radial styloid and causing injury there. Analogously, like we mentioned here, the lunotriquetral ligament allows for extension of the triquetrum, which impinges on the proximal pole of the hamate. So it's like Dr. Yao had mentioned, was 2 kind of mirror lesions.
Yes, that's right. Thank you, Eric. So it's analogous to what's happening on the slack wrist side, which gets a lot of attention. We talk about slack wrist all the time. The first stage being the scaphoid rubs up against the radial styloid and causes arthrosis at the radial styloid because the scaphoid is not pulled out of extension by the rest of the proximal row when that association between the scaphoid and the lunate's been disrupted. Analogously, on the LT side, if the triquetrum is no longer or incompletely stabilized through the LT ligament to the lunate, the triquetrum then rubs up against the hamate, the proximal pole of the hamate, rather than the radial styloid on the scaphoid side. It rubs up against the proximal pole of the hamate, developing this so-called HALT lesion. And the treatment for this traditionally is either microfracture or chondroplasty. You could see in this image using a burr to actually resect the proximal pole of the hamate to offload that triquetral hamate articulation. Thank you.
Thank you, Jeff. Thank you, Eric. It's a very beautiful case of recalcitrant ulnar-sided pain because most of the time there is, I think, a huge mistake is to focus only on the TFCC and think it is only a ligamentous problem. Since we already have done the ulnar shortening, and to dismiss another biomechanical issue, which we have a perfect example here. I would have just 2 questions to Eric and Jeff. First one, how could you explain, please, to us and to our attendees why the first during the first arthroscopy when you did the LT shrinkage, you haven't seen any arthroscopic sign of hamate chondropathy? How can you explain this?
That's right. So basically, he had a low-grade LT ligament injury that we treated with thermal capsulorrhaphy,
Yes.
which did well for 6 years. And so the the theory and we did not identify the hamate lesion at that time. So the theory or what I believe happened is that 6 years later, now in 2025, he had a new injury playing softball, and then that's when he either re-injured the LT ligament and then developed a halt lesion thereafter, or the LT ligament injury never fully recovered. He still had some micro instability, and that predisposed him to his new injury now. I think it's probably the former because for 6 years he did very well. So if it was the LT did not fully recover, then you would expect him to still have some chronic symptoms. But he did very well. And this was a new injury from playing softball. And I think he re-injured the LT ligament and developed that halt lesion this time.
No, thank you, Jeff. And do you sometimes perform a prophylactic hamate microfracture or chondroplasty or excision? Do you do this sometimes or not?
Prophylactic? No, I only do it if I
only
do. Yeah, I only do it if I see a lesion. And you saw that Eric presented that lesion, that full thickness chondral lesion on the proximal pole of the hamate. When I see that, then that's when I do the microfracture. If it's completely exposed subchondral bone and sclerotic, a large lesion, then I will do a proximal pole hamate resection using the burr, as you saw in one of those figures. But in this case, it was a smaller lesion, so I felt the microfracture would have sufficed. And we've published on the use of microfracture in the wrist with good results.
Yeah, that's my other article real quick here. This is the 2-year Journal from Wrist Surgery 2016, Microfracture for Ulnar Impaction Syndrome, Surgical Technique and Outcomes for 2 years of follow-up. Just very quickly, it's a retrospective case series from a single surgeon from 2007 to 2010. 2 years of follow-up with patients with full thickness lunate chondral lesions that underwent microfracture. 7 met criteria and dash scores improved from 58.3 to 15.1, and functionally equivalent range of motion as compared to the contralateral extremity. Here's again the second look arthroscopy. So for patients that we were able to go back and take a look for, that again is the fibrocartilage ingrowth after a microfracture.
Great, thank you. Eric, is it the end? Thank you, Eric. It's a very nice presentation. That's it. Thank you. Very nice presentation. Could you please just stop sharing your screen for the final discussion? Yes. So, do we have any comment, any question from the panelists? I see Ricardo. Finally, you managed to connect from Brazil.
Yes.
Hi, Ricardo. How are you doing?
Just fine. Yeah, it's a beautiful case. It's a different view from the ulnar side pain, and I think Dr. Jeffrey Yao and his team it's very they understand that kind of different causes of ulnar side pain. So I'm studying a lot about the ECU tendon and about the ulnar impaction, and everything is connected. So you must pay attention in this. Other causes, not so many. No, you don't speak too much about this different causes of ulnar side pain. So it's a beautiful case to discuss with very good panelists.
Thank you, Ricardo. Any other comments here? So just
we have one question from the audience.
Yes, please.
So Isadine is asking, when performing capsulorrhaphy, do you routinely use radiofrequency, or do you dorsal capsuldesis?
Thank you. Another great question. And so, as I alluded to, for the lower grade injuries, partial injuries, volar or dorsal, I do prefer to use the thermal shrinkage. I've had a long history, over 20 years of use of that, and I've had very good results of that. And we have published on that. But obviously for the higher grade injuries, more instability, Geisler grade 3, Geisler grade 2+, grade 3, grade 4, I do prefer to do the capsulodesis for those higher grade injuries.
Do you have any complication with your thermal shrinkage?
No, so it is a commonly asked question. So number one, the first thing is that the probe it must be done using wet arthroscopy. So I do most of my arthroscopy dry, and then when I decide I need to use thermal shrinkage, then I will add water, fluid, saline, because A, the probe does not work unless there's fluid, and B, also and that's because you don't want to heat up the internal contents of the carpus with a thermal probe without fluid dilution to cool the tissues. So not use, and you also have to make sure you use the correct probe. That's the other problem, is that there are many probes out there, many of them used for ablation, coagulation, but there are a number of probes that are specifically designed for thermal shrinkage, shrinkage of the collagen. And you must make sure that you're using the correct probe, because otherwise you can cause injury to the actual ligaments. Here we're basically causing the actual tightening of the collagen, not to get too far into the weeds, but this is basically done from our sports medicine colleagues who used to do a lot of thermal shrinkage for the shoulder and other joints. As we know, in the shoulder, it's fallen out of favor and had a lot of complications. I think the major reason that it fell out of favor in the shoulder is because in the shoulder, they need to move the shoulder right away. And as shown in the laboratory studies with thermal shrinkage, it takes 6 weeks for that tissue to remature. So essentially what happens is the collagen fibers, which are in the triple helix, the fibrils to form the fiber, triple helix, are held together by two different covalent bonds. There's a heat labile covalent bond and a heat stable covalent bond. The heat labile bond is the one that's disrupted by the use of the thermal treatment. And then the heat stable bonds are still intact with the treatment. So what happens is with the breaking of the heat labile bonds, there's a net shrinkage of the tissue. It's like if you put a piece of meat onto a grill, what happens? It gets smaller. And over the course of 6 weeks, those heat labile bonds reconstitute themselves. And then the tissue, this collagen strength has been restored. So you need to be able to let the collagen restore itself over 6 weeks. In the shoulder, if you immobilize the shoulder for 6 weeks, the shoulder would never move again. And that's why it failed in the shoulder. But in the wrist, because you can cast the wrist for 6 weeks after thermal treatment, the collagen rematures, and then the desired effect has been restored. So that's why we've had really good success with thermal shrinkage for lower grade injuries and for scapholunate and LT ligament injuries.
Thank you, Jeff. I think you convinced me, everyone, with this explanation, because to be honest, you're not the school of the shrinkage, but for now, I think you convinced most of us, many of us, sorry. Before moving to the next case, Carla, do you have any question? The only one who didn't ask any question, any comments? Your mic.
Two things that I was considering. One was that, or more than two. One was the popping. It still unexplained. The other, I was also, like Ricardo, thinking about the ECU. You should at least have excluded it, but then there was no reference to that, so it's not that cause is not the cause. And another thing, I was wondering, because maybe it should have been sorted with the second surgery, because when I look at the ulnar variants, it's flush, and I try to make them slightly ulnar minus. So maybe that would have protected the wrists from further degradation of the LT ligaments and this from happening. We'll never know, but I was wondering, they don't have a series of x-rays demonstrating the dynamic change in variance when you use the wrist, and it looks flush, and I would rather see it short. And that's
So
it.
Lisbon is pushing you. Jeff, what
No,
do you have
those
to
are
answer to this?
No, thank you. Those are actually very good points as well. So I did want to address, thank you, Ricardo and Carla, for both mentioning the ECU, because that is another cause of ulnar side of wrist pain that can be often neglected. We do the ECU synergy tests and look for ECU subluxation and tenderness there, and he was completely asymptomatic. But part of the reason I wanted to demonstrate this case is because ulnar side wrist pain can be sometimes misleading. As you saw from the poll earlier, many people in the audience thought that this was recurrence of the TFCC injury or the DRUJ. You saw some incongruity there, so there was some concern that that might be the cause. But both of those problems were not at risk or in play here. So I just wanted to illustrate that with this case, is that it's not always the TFCC, it's not always the DRUJ, it can be other causes. And regarding the ulnar impaction or the ulnar shortening, I do agree. I tend to try to go to 1 millimeter ulnar negative variants when I'm doing an ulnar shortening osteotomy. Although there have been many studies that have shown that even just the act of ulnar shortening, even if it's ulnar positive 4 millimeters and you just shorten 2 millimeters, even if you leave slightly ulnar positive, just the concept or the aspect of shortening and offloading the ulnar carpal joint, that provides symptomatic relief. So some people around the world just do a 2 millimeter shortening, no matter how ulnar positive they are. But I agree with you, Carla. I do the same thing. I try to make it either neutral or slightly ulnar negative.
Thank you. I think that is a good summary of the case and the philosophy of the decision making. Thank you, Jess. Thank you, Eric. The case was beautiful. I will give the floor now to Gustavo for the second case. Gustavo, are you ready? Your mic, please.
Yes, Ahlam.
Could you?
How are you doing? Okay, let's see. We have the next case. I want to introduce you Raquel Teixeira from Lisbon IWC.
Oh, thank you for the presentation. My name is Raquel. I'm a colleague of Dr. Carla Nuñes from Gustavo, and we're going to present a case. Carla, please.
No, you present, I share.
No, I'm going to present, but I need you to, I cannot control. So we have a 15-year patient. He's right-handed. He plays futsal as a federate in a club. He has no past trauma, no previous surgeries, no allergies. And he came to the first appointment after a fall from during one of the games, fall with the hyperextension of the left wrist. He has some pain in the beginning. The pain subsided, but he has still some discomfort. That's why he came to the first appointment. At observation, he still had some tenderness in the anatomical snuff box, and he had a limitation on the radial motion. As you can see, only 50 degrees flexion and 10 extension, but the contralateral side is not that good also, so it's not a really mobile wrist, but it's some asymmetry with the right hand and a limitation of the pronation. When we evaluate the strength, he had almost half of the strength of grip in the left side and on the right side, and the pinch was also limited. When you see the first x-rays, this was done on the first appointment. We already see there is a scaphoid fracture with a Scharnberg type 2, type 1, type 2. We see already a sclerosis and a gap and some bone absorption. And on the profile, you already see some deformity, some dizzy deformity on the lateral profile.
Okay, wait a second, Raquel.
Yes.
Let me see. Can you go to the previous? Okay, so we have this X-ray. So I want to ask to Ricardo. Ricardo, what do you think in these kind of cases? You order for another study, or the X-ray is enough for you?
So I always ask for a MRI and a CT scan for planning my procedure. So I studied a lot about the scaphoid non-union in teenagers because I wrote an article with Pedro Delgado and a multicentrical studying doing arthroscopy for this specific teenagers case. And there are very few papers wrote about the teenagers' scaphoid non-union. and it's a very good. There are a lot of kind of procedures that you can do for treat this kind of patients. So even it's a good patient and a good evolution for this kind of procedures and surgical treatment, I do anything for the best procedure. So I ask for a CT scan and an MRI for plan my procedure.
Okay, thanks. And what kind of information gives you the CT scan and the MRI? What do you see in each study?
MRI more for other kind of lesions like TFCC or the vascularization of the proximal pole, and the CT scan show us the bone defect, so you can see if you do have a flexion of the scaphoid, if you have a dizzy deformity. So the CT scan you can see more the bone defect, and the MRI more for soft tissue lesions like chondral lesions or associated lesions.
Okay, great. Jaime,
Gustavo,
yes.
Sorry,
yes.
Jeff has a question.
Only the last topic. There are no articles showing the arthritis after this kind of lesion. There are no article show us about the snack wrist in teenagers patients. So we can know you don't have the answer when this carpus will become arthritic. So the pathology is very few understood until now.
Jeffrey?
Thank you. Sorry to interrupt, but I just one other thing that I always think about, particularly with the athletes, is that yes, he had trauma 2 months ago, but athletes, they're always hurting themselves, and they may not the history may not be that accurate. The reason I say that is because I do see sclerosis in this scaphoid in the proximal pole that is not very common for just 2 months after an injury. So I worry that there may have been a prior injury that he just didn't think about, and then this recent injury was an acute on chronic problem. And so that's why I agree with Ricardo. I think extra imaging is helpful because sometimes it will illustrate that this non-union predated 2 months ago, and that may or may not change how you manage the patient, but a longer established non-union may be treated differently than an acute injury that happened 2 months ago. So I think that's important to discuss.
It's very, very important. Thank you very much, Jeffrey. Very nice comment from both of you, Ricardo and Jeffrey. Okay, can you go on, Raquel and Carla?
Yes. So we did ask for the CT scan just to evaluate the dimension of the proximal pole and to assess the size of the bone gap and the size, if there is sclerosis or not, and the sclerosis of the proximal pole. We didn't ask for MRI. We usually don't routinely ask it for patients that don't have any more complaints in the observation because there was not instability or ulnar side pain. It was just pain located to the radial side of the wrist. And this is the image of the CT. Carla, please, if you can start on the axial plane. We can see there is some small fragments and already some sclerosis on the borders, especially on the border or on the distal part. That's always seen on the coronal part. It seems a little bit bigger, as always. It looks a bit bigger on the coronal plane. We still see some gap, some bone erosion, and some more debris and more sclerosis on the part of the scaphoid. And also in the sagittal plane, we see the deformity, we see the size of the proximal pole. And we see also when it's going to ulnar side, a small avulsion, dorsal avulsion.
I was trying to get the sagittal plane to run, but it's not running.
Yes.
Just go in the PowerPoint. Don't try to click the image. When you go forward on the PowerPoint, it runs. I had the same problem. Next, I think.
Yes.
You see some comminution and
Okay, I want to ask,
show the dorsal
while
version.
you are trying to show the videos, I want to ask to Jaime. Jaime, what do you see? Where do you pay attention when you are seeing this CT scan with this proximal pole fracture or non-union? We don't know yet. What do you see? What kind of information you try to see in the CT scan?
So basically, there are three things we would like to be able to clarify with the CT. One is the fracture is acute or not. So you have some sclerosis in the proximal pole, you may conclude that this is not a fresh fracture. And mostly important is how big is the proximal pole and the deformity you have with the handback. Because if the deformity is quite flexed, then we will change our treatment protocol. So if the scaphoid is not very flexed and you don't have a intercalated segment deformity, we can agree to go like Delgado will do, to graft under arthroscopy, and with the traction with arthroscopy, it will reduce a little handback that you may have. But if the deformity is big and we are concerned to reduce it because it has an impact to have a short scaphoid, then we will change our way of doing and do a free graft on the knee to periostal flap.
Medial condyle.
Yeah. Because with that, you can correct more the deformity if you have one. So to have those tests are important in our view because it will change your treatment protocol.
Okay, great. Great, thank you so much. Lucian, do you pay attention to the position and the extension of the lunate?
Yes, I think you need to measure the angles of the scaphoid to understand how much is the deformity that you need to correct, like in this case, a Lysa angle or a height to length angle. And it's important to see if there is a DZ of the lunate. If you have a very small proximal pole, you won't have a DZ because sometimes it's underneath the scapholunate ligament, proximal. But if it's distal to the scapholunate ligament, the fracture line, you may have a DZ. But you can see also that there is 2 or 3 millimeters dislocation of the proximal pole. So in a child, it's absolutely it has a surgical indication, and I think that the bone loss is not so big, and we can treat it by arthroscopy. Okay.
I take
Ahlam.
Gustavo, yes. I take in account the DZ. I think first what I would say at this stage that I totally agree with Jeff. I think there was a prior injury because after 2 months you cannot have this aspect on the CT scan. That is the first thing. Because if we just focus on the 2 months trauma, we can make a mistake. We can consider it as an acute lesion, and we would have the debate of treating surgically or not this patient. But when we look at the CT scan, I think there is no discussion. It is whatever we do, it is a surgical indication. So the first thing, remind the possible prior injury in the athletes. The second thing, I would ask for a CT scan and an MRI to better view and analyze the vascularization of the proximal pole and the ligamentous lesion. And the third thing, I would correct the DV maybe by a Lynch-side maneuver, because if you don't have a scapholunate lesion, it helps to reduce the scaphoid.
Great.
That's
So how do you
my
manage
comment.
how do you manage the surgery, Ahlam? How do you start the surgery?
I think in this case, for me, it would be clearly in this young patient an indication for arthroscopic bone grafting. So as I told you before, I will start by the debridement of the nonunion site under arthroscopy. Maybe we will have a video after. The main point for me would be to manage the DZ by the Lynch-side maneuver. Be careful here because we have the gross cartilage. And after bone grafting taken from the radius metaphyse, and I would do also a metaphyseal cord decompression that I do systematically now in the scaphoid non-union. And the fixation by screw or pins, I think one or two screws without necessary compression, because we know that compression is not mandatory now for a scaphoid non-union, or pins. It depends on your habits. And because in this case, I would go for pins. I think I would see after reduction how much space, sorry, we have on the proximal pole, and I would decide between key wires. It could be here scapholunate key wires. We are used to do this for proximal pole scaphoid non-union. So arthroscopic bone grafting, metaphyseal cord decompression, and Lynch-side maneuver, the three main points of my surgery here.
Can I ask a question? Do you think it's a different treatment if you have a pending malunion or a non-union in a child like this? Is it different?
In a child?
The treatment. Yeah.
Yes. I don't have...
that...
Yes, in a child, I would ask Ricardo, because I think he said
no.
Because
my question is, as we don't know if it's a prior lesion or a recent lesion, do you think that there is a difference in treatment between a pending malunion, like 2 months injury, or a non-union, like 1 year, 2 years in a child like this for your treatment, or you would be doing only arthroscopic or your treatment will be the same, like arthroscopic debridement and correction of DZ and fixation?
In first intention, for me, in first, I understand the question now. If I decide for the surgical treatment, in this case, anyway, in first intention, it will be arthroscopic bone grafting. In first intention for me, no indication for vascularized bone grafting here or open. Because we know that we can push the indication and we have good results with the ABG. Maybe we can have the opinion.
Yeah, for me also the same. I would treat them both in the same way. So for me, it doesn't really matter if it's 2 monthly injury or 2-year injury. I will try to reconstruct the scaphoid in the less invasive way because he's a child.
Okay, great. Carla, do you want to add something?
Yeah. To me, the only difference is in a teenager, if it's fresh, you may not need graft because I would do the arthroscopy anyway. But sometimes, it's a teenager. Sometimes if the gap is very small and if it's fresh, treat it like an acute fracture. That's the only difference for me.
So Carla, you think that it is an old injury?
Yes, he's a goalkeeper and he's very motivated to play because he plays in a league. So he probably neglected the first injury and now he destabilized the fibrosis he had before. Yeah.
I like the comment of the
Great.
metaphyseal cord decompression, Ahlam. I think that's very useful, particularly in the subacute setting. Do you do anything differently, given the fact that he has open physis, open growth plate? Do you worry about doing it in those patients, or do you just go more proximal?
I would think about this, to be honest. I told you metaphyseal cord decompression, but when I look at the physis, I would think twice before doing it. To be honest, I don't know if you have some follow-up.
I
Gustavo, do you have
yes,
this?
I have
Because
done. Yes, I have done many
Argentinian are very good.
Yes, I have done this in many cases in teenagers. So the only thing I take care about this in this kind of cases is to go proximally to the ground feces. So it's very important to do it. It's the only case that I do it under fluoroscopy. So I always take care to do it between 1 or 2 centimeters proximal to the feces. So I don't have any problem with the grown feces. The thing is that we obtain a lot of cancellous bone graft, so it's very important, and we give biological support to the non-union side. So I think it's very important, but you have to be very carefully in these kind of cases. So your comment is very important, Jeffrey. It's very, very important in this case to do it under fluoroscopy.
I
And I
totally
think
agree with
also
you, Gustavo.
the comment, yes, I agree with you, but I think the comment of Jeffrey is very important because the basics of the rationale of the metaphyseal cord decompression is a blood inflow through the joints. So the question is, if there is a blood inflow, even if the metaphyseal cord decompression is proximal to the ground feces, can we have some complication like fusion of the growth feces, because of the blood inflow? But you have no problem, Gustavo, in your experience.
Yes, I have no problem in these kind of cases if you go proximally to the feces.
Okay.
The thing is that in adults, we always take or do the cord decompression exactly in the same place that you have the feces in teenagers. So it's very important to, in these cases, to go proximally. So that's why I do it under fluoroscopy to see where the feces is and go proximally to it.
Perfect.
Okay.
So just before going on, Gustavo, I will give the results of the polls. About half of the people, the attendees, would do here arthroscopic bone grafting. Okay. We have 4 people that would do only arthroscopic assisted fixation without grafting, percutaneous fixation only for 1 attendee. So most of the people would do the ABJ.
Okay, great.
Thank you.
Okay.
Thank you.
Thank you so much, Ahlam. Can you go on, Carla and Raquel?
Yes.
Well, should I pass to the next slide, right? We've discussed already.
So we agreed, we reviewing the case, our opinion is that it's not going to heal with conservative treatment. We agree that it's already probably more than 2 months old and needs debridement and it needs bone grafting. We do arthroscopic bone grafting in the majority of the non-unions in our center. We usually do the autograft bone grafting from the distal radius because it leads to a cord decompression and leads to the collection of our graft. In this case, because of the physis, we opted to go to the old cranium. Even the physis is still open, you can go distally to the physis of the old cranium, and it still leads to good results, to good union rates. We see in the first study that we bring, even with just spinning in distal radius graft, we can obtain a really good percentage of union rates in around 3 months. And that was our treatment plan for this patient. Without the distal radius graft and doing the olecranium, that leads to also to good consolidation rates. So this is the video of the surgery. Can you pause it, Carla? Sorry.
Yep.
I'll start again. So we did it, the surgery was done at 4 months. It was done at 4 months because the plan was not about the change. We already discussed with the patient and with the parents about the bone grafting and about the arthroscopic reduction. And it had the end of the school year and the end of the season, and he wanted to continue to play. He didn't want to stop the activity, so he postponed the surgery to 4 months. After the first time he went, he started complaining of this pain of the second lesion or second trauma to the hand. So now, Carla, can you go back in the beginning so it doesn't start in the medial carpal? So this is the radiocarpal joint. You just see it stops. Okay. So it's not really fluid as it should be. So can you pause it? Can you go back? Just to show there was not an injury to scapholunate injury. It was not a scapholunate injury. There is a lunotriquetral injury, a Geisler 2. It was debridement. So this is the scapholunate. It's stable. The pole always looks a little bit small on the medial carpal joint, and this is the lunotriquetral joint, and it's a Geisler 2. It was debridement, and we didn't do any additional treatments. This is the can you pause? After the debridement, the gap always looks bigger than it is, and the fragment of the proximal pole always looks smaller. Through this side, we can see the radial carpal joint through the gap. So this was before the reduction. It was just the debridement, loosening of the fragments, and with the curette and the shaver trying to debride everything. And then we did the autograph collection, and after that part, is it playing?
Yeah. Here.
So can you just go back a little bit? So after the debridement, we go out of the arthroscopy. We do the Lynchman maneuver. We put a radiolunate wire, and then put one wire in the axis of the scaphoid to do a reduction. And then we go back. You can see it here, the scaphoid wire 1.0, and then in this stage we go back to arthroscopy and we put the bone graft through insulin syringe.
Add a little detail. You see here in the bottom, this little thing here, that's a Foley catheter because the proximal pole was very, very unstable, and the gap would probably go through it into the radiocarpal, so it is protected. In this case, it's needed. Please, Raquel. Oh, sorry, I just...
No, I can put it play, I think.
Yeah.
Okay, this is the syringe with the autograft, and then with the curette and the section and the hook, we fill all the gap. Trying to increase the pressure, and this is the final result. Everything is filled with bone, and after that we go back after arthroscopy again and do the finish fixation. We opted to do pinning because at the end it was really unstable, the proximal pole. It was difficult to place a screw, and we had good results using the 3 1mm wires in the axis of the scaphoid, and we did leave the radiolunate because trying to correct and stabilize the deformity that it was left 1.4 wire through the physis of the distal radius, and then to increase the stability, scaphocapitate wire that was already left to increase the stability and increase the risk of union. So this is our intraoperative exams. Do you want to comment? We can go.
No, we can go. We will comment
We can
at the
go?
end.
Okay, so we had one complication intraoperative. So the tourniquet went on a little bit more than it should be. This was because we had a technical issue with the camera. It was not connecting. And then after the first wire, we lost a little bit reduction of the proximal pole. We had to redirect it, and it took a bit longer, but it was adequate size and pressure. But when we removed the tourniquet, we were left with this. It was like a burn, a circular burn around the side of the tourniquet. It required some chemical debridement, plastic consult, and it only fully healed at 3 months after the surgery. So, Carla, you can go. So we removed the radiolunate wire at 2.5 weeks, especially because it was locking the growth plate and we didn't want to increase the injury. We had a CT done a little bit more than 3 months. This is as same time, around 3 months, 3.5 months. We had some 50% consolidation in the sagittal plane, and on axial plate, it's difficult to see because it's a small fragment, but also on the coronal plane, we had some healing, around 30% in the coronal plane, and we removed the rest of the wires around 4 months after surgery. The patient only kept with the cast until the removal of the radiolunate, and then we switched to a removal of splint. It was all with indication of don't do any weights and don't remove it, but it was able to take it for shower and small range of motion during that time. At 6 months, we removed the CT. It was a complete healing. As you can see, there is some residual deformity of the scaphoid. We allow him to return to play at 6 months for training as a goalkeeper, and he starts playing in games around 7 months. And at 7 months, it was the final appointment. He had no pain. He has increased range of motion, even compared with the contralateral side. He has more motion on this wrist than on the contralateral side, and has a limitation of the pronation. Yeah, he regained all the strength that he had. Is the similar grip than the other side and more pinch than the other side, and he had no pain, and it was real satisfied with the surgery. And I think that's it.
Yeah.
Thank you. Gustavo? Beautiful team.
Okay. Okay, very nice. Okay, I want to ask
Carla. Sorry,
Can I
Carla,
stop?
could you? Yes.
Stop
Carla.
sharing, right? Yeah.
I want to ask to all of you if you agree using key wires in this case, or if anybody of you will use a screw.
Key wires for me. I already voted.
Okay. Jaime, Jeffrey, Eric, Ricardo, what do you think about this? Screw?
If the
Key
pole
wires?
is big enough, if the proximal pole is big enough, I do try to use a screw. If I'm able to put one guide wire down the center and I feel good about it, then I can put the screw. But if the guide wire is taking up the majority of the proximal pole, and I'm not confident that the screw, I'm worried that the screw may cause fracture of the proximal pole, then I will leave that wire and then add additional wires. But if I can go with screws, I prefer, because then we can start motion potentially a little bit earlier, even if the union hasn't been achieved.
So, Jeff, you put only scaphoid wires or scapholunate? Because me, I would put, because mostly scapholunate, 3 scapholunate key wires. Does anyone do that?
We also do it when it's more proximal, like standard type 1. In this case, when you see the intraoperative exams, you see if you did the radiolunate, it goes through the site of non-union. So it was going to displace the graft. So that's why we did it. It was big enough for this type of constructions.
Thank you.
Okay. Jaime, what do you think about this? Does the age of the patient change the method of fixation you use?
Not especially. We will try, as Jeffrey said, to hit the spot and put a screw, a small screw. But if we are facing difficulties and we have to go back and forward too many times, we will, you know, just add some more keywords and that's it. So the idea we have about the fixation is we will try to put a screw, and if in case it's difficult and we don't want to make a Gruyere cheese, then we will just put 3 wires and that's it. I don't know if the keywire from radius to lunate 2.5 weeks would make any difference in terms of healing time. So we will try to avoid that, especially if we have the screw in. And if not, we will add some keywords as you all did with the scapholunate, something like that.
But do you ever use the radiolunate keywire or never? In adults, for example.
We, even in four-corner fusions and things like that, we use it to reduce, but then we don't leave it there after, because we kind of trust that the reduction will hold with the other things in.
At the opposite of Delgado, because in Delgado paper, and I think it was Ricardo and Delgado paper, they leave the keywire for 3 weeks. That's what you have done, Carla.
I think Pedro leave the keywire for 8 weeks.
No, I think
8 weeks or 3.
I think it's 4.
4 weeks.
Yeah, 4.
Not 3, not 8. It's 4. Thank you.
Pedro right now is leaving the keywire for 8 weeks. I spoke with him about this last week. Yes, I'm sure about that.
But in the paper, I'm talking about the paper.
No, I know. But nowadays he's leaving the keywire for 8 weeks. I totally agree with him in these cases, not especially in this teenage patient, but most of the cases, if you have a huge DC deformity, I think that 8 week leaving the keywire for 8 weeks will protect the healing of the scaphoid. Ricardo, what do you think about this?
I ever use for 4 weeks in adults. In this kind of teenagers, I don't use it. I agree with Jaime. I think it's not a very solid or fixed deformity. So you can reduce, and I try to use, as Jeffrey said, a small screw. So in this case, I only put an anterograda technique for a screw in the non-union of the proximal third of the scaphoid.
Okay, I totally agree with you, Ricardo. Well, we have to close the cases, so I'm going to give just 3 little key points from each cases. As Lucian said, the physical exam leads in previously operated wrist. Clinical findings are more reliable than imaging. And as Jeffrey said, not all ulnar-sided pain is the TFCC problem. Halt, lesions, and lunotriquetral instability must be considered. As Eric showed, microfractures works. It promotes reparative fibrocartilage. As Paul Lopez-Osornio told us last week, we have to avoid to use keywires to do these microfractures. So it's always you have to have the microfractures setting. And about the second case, timing matters. So as Jeffrey says, the true duration is often unclear. Early indication improves union, and proximal scaphoid non-union you have to go with grafting and reducing the scaphoid. So arthroscopy provides precision and biology, as Carla and Raquel showed to us. Not every complication is technical, but the tourniquet injury did not compromise the healing of the scaphoid and the full return to sport. So, Ahlam, do you want to close the webinar?
Thank you, Gustavo, for this great summary. I hope everyone enjoyed the cases. Thank you. There are 2 great cases, very interesting. Thank you, Eric and Raquel, for preparing them, Jeff and Carla for joining and all the explanation, all the panelists and all the attendees. I hope you enjoyed this. I wish you a nice weekend. The next IWC webinar for the cases will be in 1 month, and we have also Journal Club. So I wish you all a very nice weekend, and thank you once again. Bye-bye.
Bye.
Thank you for
Bye.
organizing.
Thank you.
Ciao.
Fantastic.
Bye.
Thank you, everyone. Good to see you
Bye.
all.
Bye bye.
Bye.
Bye, Jeffrey.
Bye.